Hello, Paulo.
Yes, Eric, how are you?
Hey, how are you?
Good to hear you.
It's good to hear you. How have you got any rain in Houston yet?
We have rain 2 or 3 days a week regularly and very nicely.
Oh, that's very good because it's so dry there. It's terrible this time of year.
Really?
Yeah,
Not here. We
yeah.
have very nice humidity and always very green.
Oh, very good. I'm glad. So we're waiting for a couple people to show up here. Have you ever
All
done
right.
that coronary coronoscopy with the CT where you look at the origin like you're looking at a colon?
What?
It's called coronoscopy. And we do it with a CT, and we can actually look at the origin of the coronary and see if it's slit-like and actually measure it for you.
It's a CTA?
Yes, sir.
Okay.
We'll have to show you that.
All right.
I think you'd like it.
It's from the inside?
Yeah, it's like you're inside.
Because I saw the ostium of
And it has a
coronary.
subtraction. It does a subtraction of the contrast.
Huh.
And so you can actually go inside the contrast vessel, and it looks like a hollow vessel. And then you can back out to get to the origin, and then you can measure that.
Maybe that's the best way to do it.
I'll have to show it to you one day.
Very good.
Yeah, we'll set one up for you and show it to you one day.
They use it very much in surgery, the pediatricians.
Yes, oh yes.
They don't want to do a catheterization kids,
Yes.
and they diagnose the anomalous origin with intramural course by just seeing the ostium with the slit-like ostium that looks eccentric and acute angle. But that's not enough to quantify the severity of block until you need a cross-section.
Yes, you do.
These are two interesting cases of something unusual.
Oh, great. We're looking forward to it. We're waiting for a couple other people to show up here. We'll be starting in just a minute.
The people in New Jersey are coming.
Yes, sir. From
All right.
Deborah Hospital.
Before. I was supposed to go there. When I finished my fellowship, they offered me a position there.
Oh, great. It's a great place.
A great place, not as a city, but the hospital is pretty nice.
Have a very loyal group of patients there.
Yeah. Small towns,
David,
close to Philadelphia.
what's his name?
I think it's part of the Temple University. Two out of 101 attendees. Two mandaron la invitación de 101.
Paulo, we're going to go ahead and get started, and we'll record this and give this to people who haven't been able to make it. But I'm sitting here with two of our fellows, and they're anxious to get started.
All right. So we have two cases, and one has a background of what is the embryologic background for some unusual anomalies, and the other one is an acquired and congenital problem at the same time of unusual nature. So we want to talk the first on an unusual presentation of a coronary anomalies of origin, in which the principle that we are trying to promote, that ectopic coronary arteries are important when there is an abnormal ostium in itself more than ectopic origin. It's not the location of the ostium, but the way the ostium is made anatomically and functionally that is important. And since the beginning of this story, that was related to the reports by Chatlin and the group in 1974 at the U.S. Army hospital in Washington, they made a major point that anomalous origin from the aortic root is the problem. In reality, the problem is the ostium. And I'll show you how extreme is the case and how difficult it is to diagnose it in a case that has the essential anomaly of the ostium, which is only related to the ostium itself more than the direction of the proximal coronary artery or intramural course. We have seen recently that the slit-like ostia is important, the acute angle of origin is important, the ostia ridges, that is the subject of today's presentation, may be important, which is a thickening of the inner layer of the intramural coronary artery at the ostium. An intramural proximal course is super important. It's basically 99% of the problem in this important coronary anomalies. A membrane-like behavior of these anomalies is a frequent parameter to understand why coronary anomalies are also important in the function, not only in the anatomy. The systolic aortic root expansion is probably also a component with causing compression within the wall of the aorta. Spasm was considered at that time as a #1 probability of making a patient normally asymptomatic or even able to do advanced exercises, all of a sudden symptomatic and even dying of this apparently benign condition. So let's see what we know about why these anomalies of the coronary artery are so much frequent, because they are one of the most important, more prevalent anomalies that we see in humans. Why? Because there are basically two components or three components in the formation of the coronary arteries. One is a pre-epicardic organ, a group of cells that look like a grape in a very early embryo in human. We're talking about the third week of development. A group of cells that move out of the liver parenchyma, and from the parenchyma move towards the back of the heart that is now at the looping formation, and the initially naked heart myocardium becomes covered with these proepicardial organ cells to provide the heart both with the coverage, the epicardium, but especially with cells that will give both endothelium cells and mesenchymal cells within the myocardial tube. At the beginning, the myocardium doesn't have anything but myocardial cells, contractile elements. These primitive mesenchymal cells will eventually develop into smooth muscle and fibroblast. The smooth muscle is essential to identify and create the anatomy and physiology of an artery and distinguish it from a vein that is initially also, like the artery, an endothelial tube, but eventually will acquire a media, and these mesenchymal cells will provide the adventitia. This is the most important part of the coronary circulation. Tubing formed in loco, initially migrating from the liver through the diaphragm to the heart region, and eventually connecting to the aortic root in a normal event, in a normal embryo, by the effect of this other component that is so important, the cardiac neural crest cells, cells that come from the back of the embryo next to the neural tube and migrating around the tube to the visceral or the ventral part of the embryo, following the brachiocephalic branches and reaching the arterial pole of the heart. In the arterial pole of the heart, that at the beginning is a single channel, they will provide the essential component, both structural and cells that will give the directions to the organs to develop different morphologies. These cells are essential in the formation of the aortopulmonary septum, so the separation of aorta and pulmonary artery from the primitive common truncus is due to this, essentially to these neural crest cells, but also the media of the aorta and the pulmonary artery is brought by cells migrating from the neural crest, and these are initially epithelial cells that will migrate and form mesenchymal cells. But these cells will also be essential in identifying the site of origin of the coronary arteries. Initially, the site of origin of the coronary arteries is defined as the point where the in loco vascular network that has no circulation meet the aortic root and start a circulation towards the periphery. So this is what happens in the early embryo, and the determinant factor in deciding the coronary ostia is the neural crest cells. And that is what is failing in patients with bicuspid aortic valve, in common truncus, but also in coarctation of the aorta, in congenital aneurysms of the ascending aorta that come frequently with the bicuspid aortic valve. So it's a very interesting anatomy and embryology that is forming at this point. In this context, and this is an interesting series of slides that come from Spain, where we have a fellow visiting from. She's from Cadiz, but this is work that was done in Malaga. It is a group of biologists that develop a great culture on the anatomy of different animals that they follow from the embryonic stage, because they have develop families by inbreeding both hamsters and rats and mice to develop a high probability of having conotruncal defects, so bicuspid aortic valve transposition, but especially coronary anomalies. They have finally selected a family that has a 25% probability of having coronary anomalies. In this group of anomalies, the predominant is one where they see a slit-like or a tangential origin of a coronary artery. In this case, it's the right coronary artery that in place of coming here below the sinotubular junction comes a few millimeters above and goes straight down. This is seen with larger magnification in scanning microscopy, and you'll see that there is an edge here that is thicker than the rest and is in the mind of this biologist capable of moving up and down. They don't know because they don't do angiography, they just do anatomy, but there are consistently, frequently in this patient, they are not patients, they are examples of coronary anomalies in hamsters. They frequently have ectopic origin of minor degrees within the proper left sinus, for example, left coronary artery, with the tangential origin. If you do in histology a cross-section of the origin, is very instructive because you will see this is the aortic wall and this is a coronary artery that is taking a tangential origin. The ostium is, this is obviously only one section, but it gives the message, is the ostium is eccentric and is in part obstructed by this bulging ridge at the ostium of the coronary artery. Is the right coronary artery from the right sinus of Valsalva. If you do a cross-section and a larger magnification, lower magnifications, the left coronary artery is here, the right here, both are intramural inside the wall of the aorta, and you see in magnification this, what is this side, this in magnification is intramural course. You see that the aortic media is in a continuous layer of cells with respect to the coronary artery. Basically, the aortic media is the media of the coronary artery. This to lead to human pathology, the one that we studied more intensively in clinical grounds, and we remember that the right coronary artery ectopic with intramural course will have in histology this kind of appearance. The coronary artery is usually called between aorta, which is this, and pulmonary artery, which is this. This is the media, the adventitia with some little branches in space between aorta and pulmonary artery. These arteries that are ectopic are not between aorta and pulmonary artery, as frequently said, but within the aortic wall. They are surrounded by the media of the aorta, and they are distorted, they are compressed, and we will see a case of this kind with very peculiar features. We also will see a case where a case of left from the ectopic origin will be shown to be obstructed by an ostial ridge. This is not the case where the left comes from the right. This is the right sinus of Valsalva, and it goes intramurally until it comes out to to become normal and bifurcating in LAD and circumflex as it is the most frequent case, nor coming from the non-coronary sinus, which is less frequent, much less frequent. It is of this kind. Our case is one in which the ostium is in the normal side of the aortic root, but in place of coming out at 90 degrees more or less from the aortic lumen, it goes straight down inside the wall of the sinus of Valsalva, and it comes only externalized epicardially at the bottom of a few millimeters of intramural course. The first report that we have in the literature on this, we call them, or they call them ridges, is by Renu Virmani, an important pathologist that dedicated many years of her early career in Washington, also in Bethesda, the NIH, on this kind of anomalies of the ostium. So she compared in a large series of patients, some that died suddenly at 22, and some that died of something else, and looked specifically to the valve-like ridges, as she calls it, that the ostium of these coronary arteries that could have caused sudden death in some and no clinical manifestations in others. She called them valve-like ridges and implied, I don't know if it is clearly seen, the 1984, the pictures were not so clear, but this was the ridge, this type of ostium that is narrowed by the prominent ridge of the ostium. This is also one case. This is the most typical case of a ridge at this site of a tangential origin of a right from the left. You see a thickening of the wall of the aorta before the artery goes through that. And this group theorized, pathologists have a vivid imagination, but in autopsy specimen theorized that what happens in vivo is that the ridge, which is this structure inside the ectopic artery, will in systole come to touch or obstruct, they call it occlude, the opposite side of the aorta at the ostium of the anomalous artery. And these are other examples that they theorized will cause stenosis. Their conclusion was that these findings are a concern not only when the anomalous origin of the coronary arteries from the sinus of Valsalva, from an ectopic sinus of Valsalva, from a non-normal sinus of Valsalva, but also when the arteries arise from the normal sinus of Valsalva, what is proper for a coronary artery, the right from the left sinus, the right coronary artery from the right sinus. These relations may be triggering mechanism of angina and sudden death. Relations with the sinuses, no. It's really the intrinsic morphology of the ostium that causes. And this is what we are going to show in this case. This is interesting. It's only at 57 years of age that this patient comes for a second opinion, with a history of hyperlipidemia, hypertension for 10 years, progressive dyspnea, incapacitating now to the level of not allowing the patient, who is a professor at a college close to Houston. He can't talk, he can't be free of pain with emotions and with moderate exercise. But especially he was brought to the emergency room. He had the second of two syncopal spells. He passed out completely, fell on the floor. For some time, in both cases, he measured his blood pressure while he was having chest pain, hypotension, and cold perspiration, and he measured the pressure of 80 over 50 before the second time they took him to the emergency room. And the episode will last 55 to 20 minutes, 5 the first episode, 20 the second episode. In both cases, he was not shown to have any acute event like an acute myocardial infarction, but eventually he had the sestamibi nuclear stress test with the treadmill that showed anteroseptal ischemia. So he was studied by heart catheterization, and catheterization locally showed two anomalous coronary arteries. The circumflex was coming retroaortically from the right sinus of Valsalva behind the aorta and going eventually to the normal distribution of a circumflex, while the left main had something very unusual according to the referring physician. He described it very acutely as straight down course, and we're going to see a picture of this. And eventually there was one or two stenosis in the LAD and ostium of the diagonal. He was referred for a second opinion because of the symptoms that were of importance, especially because of syncope and because of the stress testing pointing to the LAD as the probable cause of the presentation. Let's see if we can see the movies. Any questions until now? So this is the first picture. It's a PA projection. The catheter is very easily approaching a left coronary artery, and it's a guiding catheter because we knew that we wanted to do an IVUS, intravascular ultrasound. In that position, the catheter was causing a gradient of 15 millimeters of mercury. And if you see, it's not very obvious by angiography, there's a little bit of narrowing at the very ostium. The blood comes back, but is almost completely occluded by a 2 millimeter catheter, guiding catheter. This is a catheter, an artery that normally is at least 3 millimeters in size, or in normal adult is even 4 or 5. In this patient, the circumflex was coming from the right, so it was expected that the left was a little smaller than the normal left main. So there is a stenosis here and a stenosis there. Mainly is the LAD that could have had a fixed stenosis there. But especially was curious to see this anomalous course. Let's go to the next. In the next, you see that the left main follows the sinus of Valsalva for a few millimeters, and then it comes out, and there's this stenosis at the beginning of the LAD diagonal bifurcation. Next. So we did a IVUS pull back from the diagonal to the ostium of the left main, hoping to see something that could explain if it was only a problem of atherosclerosis acquired, or also of something congenital as suggested by the unusual course or direction of the proximal left main. This is a pretty normal coronary arteries. This is the probe of the IVUS, intravascular ultrasound. These are marks of 1 millimeter length. This is the coronary guide wire. Pulling back, you see that at the very beginning, this is already a aorta, but at the very beginning there is something like a lateral compression, a fissure. This is the very ostium of the coronary artery, but it's very short. In the pullback that is motorized and automatic, you have no more than 2 or 3 instant pictures. So there is an impression of a lateral compression, but is a very short level where there could be stenosis. It's difficult by IVUS to be sure how important it was, but it was a clear indication that the ostium was compressed. Let's see if we can see a little better this. You see, there is a lateral compression. This diameter at the very beginning of but this is the ostium that is definitely compressed. So we tried to go with a more advanced technique to see the ostium of coronary arteries. This is provided by optical coherence tomography. This is a laser light used to show the internal anatomy of a coronary artery that is very difficult to use when you have an osteal lesion. A pullback motorized is fairly quick, and it doesn't give you much of an idea of how severe the distortion of the coronary artery seems to be compressed, not clearly obstructed. But we were interested in the very end of this pullback. This is the beginning of the main. This is the structure that we wanted to understand a little better. This is the beginning of the guiding catheter. The guiding catheter is obviously free of disease. So the next, I want to show you 3 or 4 pictures of specific sites. This is a proximal 1 centimeter from the ostium site of the left main. There is obviously distorted 2.8 by 5.7 millimeters, larger than the ostium of the distal vessel in this direction, but smaller than the distal vessel in this direction. The distal was 3.5 millimeter in around circle in cross section. But the ostium, at the ostium, you have here where the ostium is already apparent. This is already the opening into the aorta. The little part that is intramural is 4.3 millimeters by 1.5 millimeter of thickness. This is definitely a quite compressed ostium and potentially serious. Evidently, this is in a fixed mode, but in systole diastole there was an impression of opening and closing of this as a membrane. So in a close-up at this level, we define the 2 mechanisms of stenosis in this pathology by hypoplasia, by calculating the circumference of the reference diameter was 10 millimeters, and the ostium was 9.3 millimeters, so it's really a compressed vessel more than a hypoplastic vessel. But the cross-sectional area of stenosis, it was 82% in cross-section, so it's a quite severe stenosis. It's the left main that is not compatible with life. It is quite unusual that this can allow a patient to have a pretty normal life until the 50th years of age, and a very active lifestyle until it became critically important. And most likely, this is due to the fact that the aortic root with aging tends to enlarge, especially if there is hypertension, and especially if the patient is submitted to um, high-pressure exercises like lifting heavy weights, like this patient was doing for regular body training. The final? Yeah. So the conclusion that we made in this case was that the patient had both the coronary artery atherosclerotic disease with a moderate stenosis of the LAD that could be fixed with a stent, but especially an osteal stenosis of the left main, even though the left main in this case only provides to the LAD and diagonal because the circumflex has a separate origin and course. So it's a case that could be fixed with the stents or with two, one at the ostium, one in the LAD lesion at the origin of the diagonal, or with a coronary bypass surgery. We discussed at some extent with the family which was the best technique theoretically, and for his case he was worried about being able to start his academic year in the middle of August, so this was 15-20 days ago. So I said, well, theoretically it would be better for you to have two stents, but then we sort of suggested that it could be better for his late life to have a bypass. And we hoped and we agreed with this idea that bypass could be better, being a left main, because we wanted to have a picture of that ostium that we have by indirect imaging, but it would have been better to have in vivo in a still heart in surgery. Eventually, the decision was to do surgery. He had surgery. Fortunately and unfortunately, the surgeon that is very good decided to do off-pump surgery without stopping the heart, so with a mammary to the LAD, and he didn't take the famous picture of the ostium. So we're going to do another picture with a CAT scan after surgery in the next few weeks. But in summary, this is a case where you have in an adult the late manifestation of a double pathology, one acquired and one congenital, and both are important, but the osteal lesion is the one that probably related to the syncopal spells. And we will see if we can confirm with a picture by CAT scan angiography, maybe with the technique that Dr. Harrison was suggesting of seeing the coronoscopy by CAT scan at the next session in 1 month. Any other questions?
Hi, Dr. Angelini. My name's Arti. I'm one of the cardiology fellows here with Dr. Harrison. I was wondering how the left circumflex in that last case appeared. I'm assuming it looked okay despite its origin.
It was a separate origin from the aorta. It was not affected by atherosclerosis, and it was going to a single obtuse marginal. The right was very dominant, was giving a large obtuse marginal 2 or posterolateral branch, so it was a small circumflex, nothing important.
Dr. Angelini, this is Greg Hartledge, one of Dr. Harrison's fellows also.
Nice.
I have a question. Are you proposing that the fact that he had an anomalous circumflex and less flow through his left main was protective in his case, and maybe that's why he lived into his 50s?
It could be. In general, this is a case where a left coronary artery, quote unquote, is more like an LAD, like in a patient that has a patent bypass or is protected circumflex territory. In this case, the circumflex territory protection was afforded by both the fact that the circumflex was normal and from the right, but also that the second obtuse marginal territory was given from the right. So it really was an LAD alone. And this is a case that you can do by stents safely and according to all sorts of recommendations. But he had off the pump bypass, and I'm sure he's going to do very well.
And one other question. Was there anything other than just the angiographic appearance that made you want to study the ostium more? Like, was there ventriculation when you engaged, or was there osteogradient, otherwise? Like, did you FFR those other lesions and see an osteogradient? Because I didn't think that the angiographic appearance of that left main ostium was that impressive, personally.
Let's go back to that picture in angiography. I'll tell you where I got the impression that this could have been a case that I've been looking for some time, but I never found before. This is the first time I describe it with OCT. And you see here, you see pretty well the relationship between the aortic root. You see here, the aortic root and the coronary artery. Normally the coronary artery goes that way, 90 degrees away from the ostium and the aortic root towards the epicardius. This follows, but you're right, the main anomaly, more than the direction of the left main, is the fact that there was a gradient, and we wanted to know if there was atherosclerosis, and there was no atherosclerosis there, and if there was or not something more than the minimal abnormality expressed by the gradient. It was a very soft evidence. The problem with these studies is that if you have a guiding catheter that is 2 millimeters in size, and you pass through the ostium because it's not atherosclerotic, it's soft, it's a membrane, you tend to open the vessel. So you need to do a study without the guiding catheter inside, like an OCT. The OCT has a crossing profile of 0.9 millimeters, and the IVUS is 1.3 millimeters. So if the catheter was causing some stenosis, it's because of the size itself, but especially it was important to measure the cross-section in the short diameter. There are two diameters in a compressed vessel. One is short and one is long, and the short must have been abnormal and severely stenotic to cause a gradient. But you're right, it's very difficult to make a diagnosis, and I'm sure we have seen several cases with this osteal ridges that Dr. Vermani was describing in many people that died of something else that will never be discovered if not by IVUS or OCT. A very tricky diagnosis. The fact is I'm particularly interested in this pathology because I'm writing a new book, a new chapter of the book on coronary anomalies that is about the spectrum of all the anomalies of the left coronary arteries, congenital, that can cause stenosis. And this I never had the chance to document. This is a very interesting case in that spectrum. Good question. Let's go to the second case then. The second case is shorter and also very unusual, amazing. A patient that comes from Houston but actually lived in Brazil. He is an oil and gas engineer that works in Rio de Janeiro, offshore. A male of 44 that was involved in regular exercising, feeling very well, had a mild history of hypertension, well controlled with medication, and moderate hyperlipidemia, familiar. And he was not so sure that he wanted to control these risk factors, so he continued to take and not take the medicine, but he could have been in perfect shape with a little Crestor any day of his life, but he was deciding to do it only every second month for some reason. So he had no symptoms until 3 years ago, actually until 2011. 3 years ago he had the symptoms when he had a typical chest pain, prolonged and following a routine cardiovascular exertion in the gym. He had that pain in a recurrent mode after a month since the previous episode of resting chest pain following exercises that involved also lifting heavy weight. And in the second episode, the pain lasted longer time, was epigastric at the beginning with nausea and cold perspiration. It's only after 3 hours of continuing discomfort or feeling fainty that the patient was brought to the emergency room. They had only T-wave inversion in the anterior leads, and only the second day after admission in a private clinic in Rio de Janeiro, they did the cath lab procedure, and the procedure was interpreted as evidence of a spontaneous proximal LAD coronary dissection. Very astute diagnosis. I'm not sure that it was the correct interpretation, so this was one of the reasons why I was very interested in seeing a follow-up. They decided that there was a significant encroachment in the ostium and the lumen of the LAD by the dissection, by the false lumen. So they put a Taxus stent, a drug-eluting stent of the LAD, obstructing the opening of the dissection, but not all the dissection they could see, but they didn't see an exit of the dissection. He was asymptomatic until 2 months before the current admission in our hospital, something like 2 years after the procedure, when he came for a follow-up. He had the first follow-up 2 months after the stent in Houston in our office, and then in 2013 with a negative stress test. Recently, similar chest pain recurred, and especially they were at rest, and because of the typical symptoms and the history of spontaneous dissection, the patient was directed to direct catheterization in the cath lab, and these are the pictures. We will see both angiography and IVUS of the left main. So this is a normal ostium of the left coronary artery, a large left main, about 4 millimeter in diameter, and then the LAD has a stent from there to here, about 2 centimeter long stent. You probably see it at the beginning, is right there. The rest of the artery look pretty spastic, a little spastic, narrow. If you think of the size of the proximal, the distal is 50% diffuse tenosed. So we gave nitroglycerin, not knowing of anything more than this, just to have an idea of what was the full artery size with the vasodilator. This is after nitroglycerin, and you will see that you see better in the cranial right anterior oblique that there is a stent up here that is mildly stenotic, not probably the original size of the vessel at that level. But then the vessel has grown up with respect to before nitroglycerin, and there is a systolic compression, especially at this level. It is not severe, but it gives the impression of a myocardial bridge, a systolic narrowing. This is where you see the best the site and the restenosis inside the stent is not the major restenosis, it's mainly a stent that was not large enough, and Taxus doesn't prevent completely the restenotic fibrotic tissue growth inside the stent, but there's a minimal stenosis. But if you look especially at this level, the systolic narrowing is very obvious. There is no diastolic stenosis, but in systole there is almost complete occlusion of the LAD at that level. The diagonal is a nice vessel, bypassable if you want to think in bypassing, but there is no reason to think in bypass yet. So this is another interesting picture, and again the stent is up here and is okay, is not capable of causing those symptoms, but at this level you see very clearly in systole an almost complete occlusion of an LAD that is obviously inside a myocardial bridge. You can increase the size by magnification. You see at this level, this is interesting because at that level I think the dissection that is occluded, the false lumen of the dissection is occluded, stops at that level. So it's a myocardial bridge distal to a section of the left main that apparently had a dissection, and it was interesting to describe better the case with a little more evidence. This is, we don't need this. Next. It's a little spastic version. This again is pretty spastic, but this is out of sequence. We need the IVUS, or the catheter of the IVUS. Anyway, this is the right that was very large. Also in this case is a very dominant right. Keep going. Now this is where the decision was made to pass an IVUS and see if there was or not a myocardial bridge at the extent, and document where the false lumen of the dissection was, and if it was or not a part of the problem. When you have a dissection and you cover only the beginning of the dissection, you have to think that the false lumen is basically subadventitial or external hematoma, and you don't see it from injecting the true lumen. So it may become part of the problem of stenosis, and IVUS is the only way to see through the wall, and the composition of the wall will tell you if there was any residual or new dissection expanding at this time to justify for the symptoms. As you see here at the end of this, this is the probe of the IVUS, there is almost no flow. The patient had no symptoms, but there was a severe narrowing, almost complete occlusion of the LAD at the mid-distal past what looked to be a myocardial bridge. Next. So we did the IVUS, and then we'll show it to you, but then gave quickly nitroglycerin and tried to solve what could have been a dissection 2 or reopening of the dissection, or just foreign body induced spasm of the LAD. Next. We gave 2 dosages of nitroglycerin up to 300 micrograms of nitroglycerin, and you see much better now the systolic compression. That is good to see, because obviously it eliminates the probability that this was an extension of the previous spontaneous dissection. And the distal is almost baseline, but is still slow flow and narrowed by spasm. Next. After 10-15 minutes, next. Okay, this is the final picture after 300 micrograms of nitroglycerin. As you see, there is much more obvious systolic compression from here to there than what we saw before. And this is the site where the subtotal occlusion appeared with the catheter in. At this point, then we needed to obviously see the IVUS, to see the dissection, the previous dissection evolution, but also to see if this unusual, the catheter with IVUS passed through without any resistance. The probability of trauma or dissection from the catheter passage was very low. So we wanted to see if this was a case of many that are published and we see in our practice, cases of myocardial bridges complicated by spasm, like transmetal angina based on spasm at the level of the myocardial bridge. Next. Next. So this is the final picture that shows a recovery of the original size of the vessel, and we can change the observation to the IVUS that is in another study. The ventricle was pretty normal. Let's see if I can convince you now in a pullback. This is automated and fairly quick. There are some 8 centimeters of the coronary arteries that are being described by IVUS. You see here there is a typical sign of myocardial bridges. That's called the half moon sign. And then you see that this IVUS is totally compressed by the artery at that level. Here, more proximally, you see something around the artery that is black, that shows the typical appearance of a clotted false lumen. As we pull, we see the systolic compression in systole and diastole. The lumen changes dramatically. Look here, in systole and diastole, the lumen, one of the diameters is almost double in diastole than in systole. Now we see very clearly a dark shadow that is the half moon sign of a myocardial bridge. And look at the systolic and diastolic variation in the size of this artery. And here now we see the appearance of the stent. The stent. This is the appearance of a clotted false lumen. This is soft plaque, but it's actually a clotted false lumen. The artery is up to the media is up there. So there is plenty of vessel that was clotted around the stent. The stent is a mild restenosis, nothing serious, but is typical of Taxus stents that don't prevent restenosis as effectively is other chemical that we have been using more recently. Next. Okay. Now there is a slide. Final slide. So what we presented is a case where apparently a spontaneous dissection occurred in a patient that was treated quite effectively in Brazil with a stent, but kept a patient liable to the result of a pre-existing congenital condition of myocardial bridging, and the development of this unusual spasticity. Basically, this is a presentation of Prince metal angina, is probably related to the irritation caused by the false lumen that now is occluded. It doesn't communicate with the true lumen, but it's still an irritant for an artery that inside the myocardial bridges has an increased tendency to spasm. Acetylcholine has the capacity of causing a spasm in the, we never showed the acetylcholine test, the angiogram. We show briefly the angiograms of after the left ventricle. Okay, this is after the left ventricular angiography. We give nitroglycerin. Is this the next? Yeah. Is it the next? There is severe fix narrowing now, and this is the worst. So there is an acetylcholine related, not anymore stenosis from the catheter going in and exciting the intima or the endothelium. This is acetylcholine induced spasm that is defining endothelial dysfunction, spontaneous spasticity. So we demonstrated that there are two conditions in this case. One is not atherosclerosis, but spontaneous dissection, which is basically a disease of the media, is rupture of the media and rupture of the intima at the final event. And myocardial bridging with increased spasticity that predisposes to spasm. This is something we have described in several cases recently because we have been using acetylcholine more frequently, aware that coronary arteries are normal or abnormal not only in the baseline anatomy but in their function. Function is especially related to spasticity, to the tendency for the media of the artery to excessively contract and cause spasm disorderly in different times of the life of the patient. Any questions? Do we have the group in Deborah Hospital connected?
No, Dr. Wagner couldn't make it. He's basically in the cath lab. He's an angioplasty guy, and so we will give this to him as a video.
All right. Very good. We want to ask also the opinion of John Tobis about this IVUS of the dissected and myocardial bridge coronary artery, because he probably has interesting observations if we can review it with him. Very good, Eric.
Thank you so much. Next time we get together, we'll show you the coronoscopy of the origin.
It's not a good term, coronoscopy.
Well,
it looks very much smelly.
We can coin something in Italian, perhaps.
But I know that there is radiologists like to go into the colon and do virtual colonoscopy and now coronoscopy. Very good.
Not to be mistaken for colonoscopy.
Yeah, close but not the same. Thank you very much, Eric.
Thank you. Arrivederci.
Bye-bye, arrivederci.